Good evening, dear students. Today we are going to deal with exodontia and pediatric dentistry. Pedodontics, how the society sees it, how mother sees it, and how children see it. Children will see you as a monster, and the reality will be like this in the last picture. The contents of the presentation would be introduction, topical anesthetics and local anesthetics, indications and contraindications for extractions, armamentarium, and the procedure of extraction. First of all, you have to know that child patient will be fearful for all the dental procedures, especially extraction procedures. For carrying extraction in a good manner, that you have to know child psychology, anesthetic agents, and behavior guidance. You should have lot of empathy and rapport with the patients. You should establish rapport. What is extraction? Extraction is the painless removal of the whole tooth or tooth root with minimal trauma to the investing tissue so that wound seals uneventful. Indications for tooth removal: broken down teeth with periapical lesions or cellulitis, carious, fractured, and non restorable tooth, supernumerary teeth, over retained primary teeth, submerged or ankylosed teeth, ectopically positioned teeth that cannot be brought into the function which has been shown in the picture, for tooth which has to be removed for orthodontic purpose. Natal and neonatal teeth which are present at the birth or after the birth. What are the contraindications for extraction of teeth in children? See, the child is having bleeding disorder, acute infections like stomatitis and acute Vincent infections, herpetic stomatitis, acute perissementitis, acute dentoalveolar abscess, acute cellulitis, malignancy, teeth getting irradiation, acute or chronic heart disease, congenital heart disease, and kidney disease. These are the conditions where you will avoid extraction in children. For proper removal of the primary teeth, you need to know the differences between primary and permanent teeth. See how it is going to helpful in your extraction. I'll be dealing it in later slides. The size of the primary teeth are smaller in every dimension. Shape of the crown of primary teeth are more bulbous. The furcation is positioned more cervically, so that you have to have that wider beaks for the primary forceps, and you should not place deep because the furcation is positioned more cervically. You might inadvertently touch the permanent tooth bed. The physiology of root of primary teeth resolves naturally in permanent dentition. Resorption is normally a sign of pathology. The support of the bone of alveolus is much more elastic in younger patient, as you all know that. As I said, these differences means that there are some modifications of extraction technique in children. Type of forceps. The beaks and handles are smaller to accommodate more bulbous crown. The beaks are more curved in forceps designed for removal of primary teeth. The wide splaying of the primary molar roots means that more expansion of the socket is required. Due to the relatively cervical position of the bifurcation in primary molars, it will be injudicious to use forceps with deeply plunging beaks. If you place it deeply, you might inadvertently extract the permanent tooth bed also. So avoid that. Avoid blind investigation of primary socket with instruments so that you might injure the permanent tooth bed. Because of the physiological resorption, it is often preferable to leave small fragments in situ in root fractures. These are the forceps which you use for pediatric dentistry, children's pattern extraction, British and American types of style of forceps. You can see in picture. These are the extraction forceps which you use for permanent dentition. We'll be showing it in the department also, so that for your brief idea, I just displayed the figures. This is how the design will be for the primary forceps. These are the elevators, commonly used elevators in cases of root stems, or if there is any tooth which you have to extract, which is embedded in the bone. Usually elevators will be used in permanent dentitions, not in the primary. So the major part in extraction is giving local anesthesia to the child. How are you going to do it? Is it pleasant to the child to give local anesthesia? Yes, if you know everything, it is pleasant, and you have to pre-operative prepare the child and the parent as well. What are the parent pre-preparative phase? The parental consent before the procedure instruct the parent not to discuss with the child what the dentist will do, let the dentist do it. Pre-operative preparation of the child will be armamentarium should be kept behind the chair. Never hold the needle in front of the child. Always hidden by the fingers. Before giving the explain the child that the sensation of the pinching or hand biting may be felt. Make the child to realize the difference between pressure and pain. Explain the sensation of numbness to the child. This is how you need to transfer the needle. Children are very smart. You can see in the second picture that child is seeing. So we prefer to hand over the instrument from the assistant to the pediatric dentist in the above picture, that is picture A. And then always, this is my gold standard protocol which we used to follow in pediatric dentistry. Topical local anesthesia for 1 minute, preferably longer for maximum effect. Lidocaine, that is 3 to 5 minutes onset of action. Benzocaine 30 seconds. Benzocaine is fast acting local anesthetic. The selection of needles, say local analgesic needle section, a 30 gauge 2 centimeter needle is recommended for infiltration analgesia. A 27 gauge 3 centimeter needle is recommended for block techniques, where our ability to aspirate is more crucial for intraligamental and interpapillary technique. A 30 gauge 1 centimeter needle is used. See, in adults, it should be 6 above the occlusal plane. Whereas in children's, 3 years below the occlusal plane, 6 years at the occlusal plane, 12 years, as I said, above the occlusal plane. This is how you will give mandibular block. In case of children and adult, these are the differences. Extraction technique. See, for the extraction technique, you need to know the patient position first. The child should be seated in a dental chair, reclined about 30 degrees to the vertical for extraction under local anesthesia. Under GA, supine position is preferable. Operator position, when removing upper teeth under local anesthesia, the operator should be in front of the patient with straight back and patient mouth at level just below the operator's shoulder. A right-handed operator removes the lower left teeth from similar position in front of the patient, except that the patient mouth is at a height just below the operator's elbow. When removing the teeth from the lower right, the right-handed operator should be behind the patient with the chair as low as possible to allow good vision. This is a very important factor which you need to consider when extracting the lower teeth. For maxillary extraction, the chair should be tipped backward and maxillary occlusal plane is at 60 degrees to the floor. The height of the chair should be at the patient's mouth is at or below the operator's elbow level. For extraction of the mandibular teeth, the patient should be positioned in a more upright position. The occlusal plane is parallel to the floor. The chair should be lower than the extraction of the maxillary teeth. These are the factors you need to consider while removing maxillary and mandibular teeth. For all maxillary teeth and anterior mandibular teeth, front and right, the chair position will be from 9 o'clock to 12 o'clock for the posterior mandibular teeth and in front of the behind and to the right. Working hand. See the working hand, this is how you need to hold the forceps. Your 3 fingers and thumb should support. Your little finger should be in such a position to support the instrument. The non-working hand plays an important role as the working hand. It retracts the soft tissue to allow visibility and access. It protects the tissues. If the instrument slips, it provides resistance to the extraction forces on the mandible to prevent dislocation. It provides feel to the operator during the extraction and gives information about resistance of the removal. The non-working hand supports the tooth for extraction and reflects the soft tissue in this manner. You have to place your non-working hand to support the bone. This is how you will place for different quadrants and different scenarios and different extraction of the tooth. Order of the extraction. When performing multiple extractions in all the quadrants of the mouth, especially if under general anesthesia, the order of the extraction is as follows. Symptomatic teeth are extracted before balancing extractions on the opposite side. Lower teeth are extracted before the upper tooth to eliminate bleeding interfering with the surgical fluid. If there are symptomatic teeth in all quadrants, right-handed operators should begin with the lower right extraction. This minimizes the number of changes of the position of the surgeon, which will reduce general anesthetic time. So now we are going to discuss about how the different type of tooth will be extracted in different manner. For upper primary and permanent anteriors, when these teeth are in normal position, forceps used for primary teeth, upper primary anterior, primary roots, upper primary root, forceps permanent, upper straight forceps. Operator stands in front of the patient, patient's mouth just below the operator shoulder, apply the forceps beaks to the root, clockwise and anti-clockwise rotation about the long axis. This is how you need to be placed, and then this is how you need to extract the upper primary and permanent incisors. Upper primary molars, widely splayed roots, considerable expansion of the socket is required. Upper primary molar forceps are applied to the roots in initial movement, palatally continued with buccal directed force delivered to the tooth. See, palatal, buccal, and fully buccal. The tooth will be out of its socket. Upper primary molars. This is how you need to place. Upper premolar forceps used. Upper premolar forceps removed by the buccal expansion. This is a permanent tooth. This is not primary. Upper permanent molars have forceps left and right. Upper molar forceps removed by expanding the socket in the buccal direction. Lower primary anterior forceps, lower primary anterior and root forceps extracted same as upper anterior. Similar position for upper teeth. Patient's mouth just below the operator's elbow. Same manner as their upper counterparts with rotation about the long axis using lower primary anterior or root forceps. This is how you need to extract the lower primary anterior. The lower permanent anterior root of lower incisors have thin mesotissual and rotation is likely to cause root fracture, so the most effective method of removal is to apply lower root forceps and expand the socket labially. Permanent lower canine may be delivered by rotatory movement or by buccal expansion. Lower primary molars, forceps, lower primary molar forceps, two pointed beaks which engage the bifurcation, buccolingual expansion of the socket. After the application of the forceps, a small lingual movement is followed by a continuous buccal force which delivers the tooth. Removing lower right teeth, the operator stands behind the patient. This is how you need to remove the lower primary molars. Lower premolars of permanent teeth. Forceps lower premolar removed by rotatory movement around the long axis of the tooth. Lower permanent molars, two designs of forceps used. Lower molar forceps, forceps of Cohen design. Lower molar forceps have two pointed beaks which are applied in the region of bifurcation, buccal and lingual. Apply the forceps and move the tooth in buccal direction to expand the buccal cortical plate. After the extraction, this is a very important aspect, that is how to control hemorrhage in children. Compress the socket, keep gauze firmly between the jaws. Bleeding is more and cannot control by pressure. You should use adrenaline on gauze or thrombin on gauze, gel foam dipped in thrombin. Any bleeding should be arrested before the patient is allowed to leave the surgery. The patient and the parent should receive instructions on simple methods of hemorrhage control. After the surgery, ice pack should be advised. Eat soft and cool foods. Seek medical attention if pain after 48 hours or abnormal bleeding. And I always recommend emergency contact should be given to the patient after the extraction. Post-operative instructions for the child and as well as for the parent. The child should not be dismissed until blood clot is formed. Hold a small cotton roll between his teeth for half an hour, not to bite his lip. Do not disturb the area the tooth was removed. Do not rinse mouth for 24 hours after extraction. For parent, reinforce the child for instructions that are already given to the child. Light meal with no hard food. Analgesics is prescribed. The extraction was traumatic and antibiotic coverage is done if the area was infected. Next, the pain relief. Simple analgesics are usually liquid. Paracetamol, 120 milligrams for 5 ml, 4 times daily for those under 6 years of age, 250 milligrams per 5 ml in 5 ml. 4 times daily for children aged 6 to 12 years is ideal. The patient is given review appointment but should return sooner if there are any problems with bleeding, excessive pain, or swelling. A telephone number for contact in an emergency must be provided. What might be the post extraction problems in children which are frequently seen? Post extraction problems are rare in children. Dry socket does not seem to occur after the of primary teeth, but it can affect older children. Post operative hemorrhage is an occasional problem with children and can be impressive following multiple extractions under general anesthesia. Usually, pressure applied with gauze or a handkerchief is effective. If not, sutures with or without hemostatic gauze must be used. What are the factors that should be considered? Avoid injury to the soft tissue such as tongue, lips, gingiva, cheeks while extracting. Avoid injury to the underlying developing permanent teeth and other hard tissue such as bone and adjacent or opposing teeth. Use the radiograph to determine size and shape of the roots, amount and direction of the root resorption, position and stage of the development of underlying permanent tooth. Any pathology. Finally, I would like to conclude that for the young child who requires the removal of primary teeth, the dentist should recognize the proper sequence of all the procedures. The dentist prepares the child by using a sensitive approach through his selection of words that indicate to the child the nature of the procedure. Thank you. These are the references which I advise you to go through. I advise Pediatric Dental Medicine by Donald J. Forrester if you can, but if you cannot, Pingham or Dr. Muthu and Shukma book is good enough. Thank you.